Good morning. For today's lecture, we will have a brief discussion on management of Class 1 and Class 2 malocclusions. As for the learning outcome, at the end of the lecture, you should be able to identify the etiology of Class 1 malocclusions, midline diastema, crowding, spacing, and rotations, and also Class 2 Division 1 and Division 2 malocclusions. Also, you need to be in a position to formulate the treatment plan for Class 1 malocclusions, Class 2 Division 1 and Division 2 malocclusion. We shall begin with the management of Class 1 malocclusion. So what are some of the variations or deformities which are associated with Class 1 malocclusion? So there can be bimaxillary protrusion or proclination. There can be crowding of maxillary or mandibular teeth, and also there can be presence of spacing between the teeth. There can be rotated teeth. There can be open bite, deep bite, or presence of cross bite. So we shall start the discussion with bimaxillary protrusion. So here are some of the features of bimaxillary protrusion. So they are basically divided into skeletal features and dental features. So the dental features here are dental bimaxillary protrusion, that is proclination of the upper anteriors and the lower anteriors, decreased interincisal angle, and also spaced teeth. And you will however notice a normal canine and molar relationship. And what are some of the skeletal features? Prognathic jaws, increased A and B angle. The patient will have a convex profile and also presence of everted lips. So here you can see intraoral images which show the patient having a class 1 molar relationship. However, you can see variations in transverse vertical or the sagittal plane, resulting in anterior crowding or presence of a midline diastema. Also, certain teeth can be rotated, there can be generalized spacing, or there can be a mild amount of crowding seen either in the upper or the lower arches. So how do you diagnose these patients? So you will have to record a detailed case history, conduct a thorough clinical examination, take impressions and post-study models, and also you can subject the patient for radiographs such as IOPA, OPG, lateral cephalogram, and also you can take some intraoral and extraoral images of the patient. However, the treatment is aimed at correcting the following, that is, correcting the spaced teeth, correcting the crowded teeth, correcting deep bite, correcting open bite, correcting cross bite, and also correcting the rotation teeth. So once you've identified what the problem is, so you have various options of treating this particular case or this particular deformity, and these can be using fixed appliances, removable appliances, or there can be a surgical correction or an intervention in these patients as well. So when it comes to fixed appliances, as the canine and the molars are already in a class 1 relationship bilaterally, premolars can be extracted followed by retraction of the anterior teeth. However, if the extraoral features are congenial and ideal, you can also do an en masse distalization of the teeth after extracting the teeth. However, if the patient prefers or you feel that the severity of the malocclusion can be treated with removable appliances, you can have several variants of a labial bow, and these will help in the reduction of the proclination of anterior teeth, or you can correct mild rotations and also closure of mild space between the central incisors or between centrals and laterals, or any generalized spacing which might be existent in the anterior or the posterior arches. When it comes to surgical corrections for the maxilla, you can perform a Lefort-1 osteotomy. And for the mandible, you can subject the patient to a bilateral sagittal split osteotomy. That's only in severe cases of bimaxillary protrusion. However, under normal circumstances, fixed or removable appliances will suffice and you can achieve excellent results. So now that you've identified that a particular patient has spaced dentition, so how do you go about treating this case? So if you see that there is generalized spacing, you have to eliminate the cause. And if the patient has microdontia, so you can eliminate space between the anterior and also leave a space between the canine and first premolar, and also place a prosthesis to eliminate this particular additional space which is a resultant of microdontia. If you notice spacing with proclined teeth or proclined anterior and posterior teeth, then you can use a labial bow, or you can also use elastics with fixed and removable appliances, which will aid in closure of these generalized spaces between the proclined teeth. So, if you find crowded teeth, and how do you go about treating this? So initially you will perform a space analysis to find out the discrepancy between the tooth material and the arch length, and the results of the model analysis will give you a better idea of how to treat this particular individual. If you see a crowding of up to 4 millimeters, then probably it's easier to treat this using non-extraction approaches, which has proximal stripping, or you can procline the anterior teeth to relieve this crowding. If on the other hand the crowding is between 5 to 9 millimeters, so extraction may be required in these patients. However, you can use certain combination approaches, that is arch expansion. You could perform proximal stripping and distalization in these individuals to gain that additional space. However, if the crowding is severe and in the range of more than 9 millimeters, extractions will definitely be needed, as the amount of space gained by arch expansion or proximal stripping is not enough to relieve the amount of crowding which is existing in a particular individual. So you have to decide this on a case-by-case basis as to what kind of extraction or proximal stripping or distalization or arch expansion or any of these combination approaches you're going to follow. Which teeth to extract again depends on the canine relationship and also the prognosis of the individual teeth, and also on the profile of the patient. Rotated teeth, how do you think we can treat or go about treating these teeth? So basically the tooth which has rotated along its long axis results in a rotated tooth. It could be either distolingual or mesiobuccal, or mesiolingual or distobuccal. These teeth do require additional amount of space for us to derotate and place them in a well-aligned arch. So how do you go about gaining the space? So you can use the same mechanics we've discussed for gaining additional space to derotate these teeth. However, if you come across a single tooth which is rotated, you could probably use a double cantilever spring to derotate that particular tooth. Sorry. However, if you come across multiple rotations, as in the image you see on the right, it would definitely need fixed orthodontic therapy. What you need to understand here is, as the relapse rate of rotated teeth is more, it is always better to overcorrect rotations, and more often than not, you would definitely need to retain them using permanent retention. So now coming to deep bite. So how do you go about treating this? So basically deep bite can be classified into a skeletal or a dental deep bite. And there are certain factors you have to consider before correcting these cases or these patients with deep bite. So you have to consider the age of the patient. You have to consider the growth pattern, which could be vertical or horizontal or a combination of both. And you also need to consider the anterior gingiva and tooth display, the health of the gingiva, the periodontal health of the patient, and also the health of the root structures of the anterior teeth. So all these factors play an important role in determining how you're going to go about treating these deformities. So a deep bite can be corrected using two mechanics, that is intrusion of anteriors or extrusion of posteriors. So when it comes to treating deep bite, you can use an anterior bite plane, which is made behind the incisors and canines. The bite plane needs to be flat and should not be inclined so as to avoid proclination or proclining forces on the mandibular incisor teeth, which can lead to deleterious effects for these anterior lower teeth. Also, the thickness should be enough to open the bite in the premolar region by around 4 to 5 millimeters. So you have to keep it in consideration when designing this particular appliance. As the patient starts wearing this appliance and as you see the overbite being reduced, you can add additional acrylic to raise the platform, and you can continue opening the bite and thereby reducing the overbite for this particular patient. Anterior biplane also will prevent the lower anterior teeth from contacting the upper cingulum or gingiva. This results in an intentional posterior open bite, and the nature's response would be to supra-erupt. Alright, so there will be supra-eruption of the posterior teeth to achieve occlusal contact, thereby correcting the anterior deep bite. So when the anterior biplane is removed and the posteriors occlude, the anterior teeth would have uh, moved or would be placed in such a position which establishes normal bite. So treating an open bite will require a posterior bite plane, which will enable the supra-eruption of the anterior teeth, and you can also use box elastics to assist you in establishing a normal overbite. And to treat a cross bite, you can use a cross elastic, which is stretched from the buccal aspect of an upper tooth to the lingual aspect of a lower tooth. And you have to, however, consider placing bite blocks or bite turbos so that there is enough clearance between the upper and the lower teeth, and this will help in treating crossbite. So that was the treatment options we had for class 1 malocclusion with the crowded teeth, with bimaxillary protrusion, with spaced teeth, deep bite, cross bite, and open bite. So now we shall continue with the management of class 2 malocclusion. So when it comes to correcting class 2 molar relationship, the treatment is basically aimed at relieving crowding and any associated irregularities of the teeth to establish a stable incisor and molar relationship, or a class 1 molar and incisor relationship. So the treatment planning will include mechanisms for overjet reduction, overbite reduction, relieving crowding and local irregularities, expansion of the constricted arch or arches, correction of posterior crossbite, correction of unstable molar relationship, and also normalizing the perioral musculature. So the treatment of skeletal class 2 will involve growth modification, camouflage, and also surgical correction of one or more jaws. So here's an illustration which shows how you can go about treating a class 2 patient. You can divide them into a growing patient and a non-growing patient. I'll give you 10 seconds to visualize the whole illustration, and then we shall go into the details. So basically, in a non-growing patient, you have to consider treating these patients through orthodontic camouflage, either by extraction of some teeth or in both the arches. And also, if it's a skeletal class 2, then you might need to subject the patient to a surgical intervention using either maxillary setback or a mandibular advancement, or at times both. So that will be the way ahead for treating a non-growing patient. Whereas if it's a growing patient, you can use headgear to restrict the maxillary growth, or you can subject the patient to headgear and a myofunctional therapy, or myofunctional therapy alone. So here we will discuss very briefly about growth modification, as we've already discussed at length in another chapter. So here, correction of the mandibular deficiency, you can use any of the appliances listed, that is twin block, activator, by nature, or Frankel appliance. You can also correct maxillary prognathism using a face bow with headgear or a maxillary intrusion splint, or you can use a combination of both, that is fixed functional appliance with headgear, or you can use several of these combinations to go about treating these patients and modifying growth. And when it comes to camouflage, which is one of the commonly used techniques to treat class 2 malocclusion. So there are certain ideal requirements for this particular treatment. They have to be adult patients. There has to be a mild to moderate skeletal class 2 malocclusion, or the patients need to have a good vertical facial proportion with neither a deep bite or an open bite, and the teeth have to be reasonably well aligned so that extraction space is available for retraction, and it doesn't lead to any kind of crowding, or there isn't any severe crowding associated with any of the clinical features you see in class 2 patients. So how to do a camouflage? You can camouflage this underlying skeletal discrepancy by orthodontic tooth movement. So you can subject the patient to extractions. If it's the upper arch, you can correct overjet and overbite through extractions, and for the lower arch, you can correct the unstable molar relationship. You can relieve crowding. You can also correct the curve of SP, and also treat deep bite. However, this would be to establish a correct molar and incisor relationship. So you have to always bear in mind the final position of the molars and the canines, and then your treatment plan needs to be framed. You can also use molar distalization to treat or correct cluster-molar relationships. So extractions of upper premolars only can also be considered when you see that there is a well-aligned arch, and also the profile of the patient is quite ideal. In such cases, you can consider extraction of just the upper first premolars to camouflage the deformity you notice in class 2 malocclusion states. So when it comes to surgical correction, this approach you will be utilizing when you see a severe mal relationship between the upper and the lower arches. So these can be either a maxillary setback or a mandibular advancement. Any associated deformities, that is the correction of deep bite or correction of cross bite, as we discussed earlier, you can use removable anterior bite planes to encourage vertical development of the posterior dentoalveolar segments, that is supraeruption of the posterior teeth, or you can use fixed appliances to intrude the upper or lower anteriors to treat deep bite as well. When it comes to correction of cross bite, you can use springs or screws such as coffin spring, quad helix, and also you can use cross elastics. You can place lingual buttons and use them to engage the elastics. So there are quite many ways of correcting a cross bite. So you can utilize one or several to go about treating these associated deformities, which go hand in hand with the correction of class 2. So when it comes to class 2 division 2, there are certain treatment objectives you have to meet. That is the relief of the gingival trauma. This could be either due to a deep bite or a traumatic occlusion, or any other form of trauma the gingiva is subjected to because of malposed teeth. So the next would be the correction of the incisor relationship. and also the relief of crowding and minor irregularities such as crowded teeth, rotated teeth, proclined teeth, retroclined teeth, and so on. So you can achieve these through the alignment of incisors using either a removable appliance or a fixed appliance. The deep bite can be again corrected either through a removable appliance or better with a fixed appliance, which can intrude upper and lower incisors, and also to correct or establish a stable relationship with the molars by distalizing them. So these will form some of the goals you'll have to achieve in correcting class 2 division 2 cases. Also, any um, existing habits you might come across have to be intercepted, and the final objective or the treatment goal should be to cause cessation of these habits and thereby prevent deleterious effects from setting in. So these will form the treatment objectives and treatment goals when you're treating a class 2 division 2 individual. So with that, we have reached the final slide. Um, so we shall. So with that, we've reached the last slide of today's lecture. So today we've discussed briefly about the management of Class 1 and also Class 2 Division 1 and Division 2 malocclusions, and how the different treatment mechanics are used to treat these malocclusion states. So with that, we shall wind up today's lecture. Thank you so much for listening.